Great. Give everyone a minute or so to join and we'll kick things off. Great. Well, I think we'll get started for the sake of time. Hi, everyone. Welcome to the National Blood Clot Alliance's inaugural Journal Club session. I'm Taryn Petrikis. I'm the Deputy Director at the National Blood Clot Alliance, or NBCA. For those of you who might be new to the organization or not familiar with us, we are the leading nonprofit organization in the U.S. that's dedicated to advancing the prevention, early diagnosis, and successful treatment of life-threatening blood clots, and we primarily focus on DVT and PE. We're patient-led, with 80% of our board of directors having been personally impacted by blood clots themselves or a close family member. We're guided by a medical and scientific advisory board that's comprised of nationally and internationally recognized experts in thrombosis and thrombophilia. And we accomplish our mission through a variety of different programs, including building public awareness, educating patients and healthcare professionals, helping to advance patient-centered research, and promoting supportive public and private sector policy. So today's session will be discussing association and changes in antithrombin activity over time with responsiveness to enoxaparin prophylaxis and risk of trauma-related venous thromboembolism. Our panel today is comprised of leading trauma and VTE experts, including two of the paper's authors. Just a few final housekeeping items before I hand it over to the panel for their introductions. There will be time for questions following the presentation, so please use the Q&A feature that's on your toolbar, and you can submit any questions for the panelists there. We'll get to as many as we can, as many as time allows. And the webinar will last approximately 1 hour. The session is being recorded, and we'll share the link following. And with that, we'll get started, and I'll hand it over to Elliott to kick off introductions.
Great. Well, thanks for the introduction. We're really excited to kick off this new idea of the NBCA Journal Club. I've got three excellent panelists with me who I'm going to ask to introduce themselves after I introduce myself. My name is Elliott Haut. I'm a trauma surgeon. I work at Johns Hopkins. I have been working in the VTE space, both in trauma and non-trauma patients, for going on 2 decades now. I'm a proud member of the board of the National Blood Clot Alliance. I'm the only physician. When I meet with the other board members, as Taryn just told us, lots and lots of patients and patient advocates. So with that, I'm going to turn it over to the team. I'm going to start, and I already cleared with everyone. I'm a first name basis person, so I'm going to introduce Bill Geerts. And Bill, maybe you could just tell the audience about yourself, and then we'll go to the rest of the team.
Perfect. Thank you. Good afternoon, everyone. And I want to add my welcome to all of you on this first event for NBCA. I'm Bill Geerts. I'm a thrombosis specialist in Toronto. My career has primarily focused on prevention of VTE, and I have a particular interest in VTE and trauma patients. I'm happy to have been asked recently to join the Medical and Scientific Review Board for NBCA, and I'm very excited for this presentation today.
Great, thanks. And then the next two are co-authors on the paper we're going to be discussing today. Jessica Cardenas, maybe you can go first.
Hi, sure. Jessica, I just want to thank the organizers for having us today, and I'm an assistant professor in the Department of Surgery at the University of Texas Health Science Center at Houston. My background is in basic science and coagulation biology. I study hemostasis, thrombosis, and mechanisms of thromboinflammation in the critically ill.
Great. Next up, Bryan Cotton. You're on mute, Bryan.
Sorry about that. I'm the less interesting and less fun, less intelligent version of Dr. Cardenas, or her sidekick, should I say. I'm a trauma surgeon in Houston at University of Texas Health Science Center, where I've been the last 15 years. My interests are mostly in bleeding, but in the last few years have pivoted as we've gotten more bleeding survivors. We're now seeing some of the sequelae of that bleeding experience, which is VTE. And I've been working with Dr. Cardenas here for a while, trying to, one, tackle bleeding, but then more recently, tackle some of the challenges of the clots and the survivors.
Great. So now that you've all met the panel, what we're going to do is we're going to get started because we didn't know what the audience was going to be like. I've asked Bill Geerts to give us a kind of a brief primer on VTE and trauma. For those of you who don't know, he's humble. He won't tell you, but he's kind of the godfather of VTE and trauma. So you're in for a whirlwind of exciting slides from Dr. Geerts. Bill, you're up.
Thanks very much, Elliott. So what I'm going to say in the next few minutes is very brief summary of a large body of evidence. We are all aware that VTE, which includes DVT and PE, are common complications in trauma. Huge strides have been made in defining the risk of VTE in trauma patients and in preventing clinically important thrombosis in trauma patients compared with when I started in practice first, but we still have a way to go. And this journal club today is part of that, where we're going with this. And I just want to contrast very briefly where we were when I started in practice in 1986 at the largest trauma center in Canada. No prophylaxis was used here or in most other trauma centers in the world. It just wasn't a priority. Bleeding was still the primary and almost exclusive focus of trauma in those days. There was not a single mention of thromboprophylaxis in trauma patients in guidelines. Now, if we move to, and part of the reason for this is a concept that I believe over the years has held true, and that is, in the old days, although trauma patients clearly do try to die from bleeding to death often, the risk of bleeding in trauma was felt in the past to be a risk that extended for quite a long time. Whereas the risk of thrombosis was felt to be quite significantly delayed. And this focus on high bleeding risks led to a very conservative approach to using anticoagulant prevention in trauma, whereas in other patients, in elective general surgery, orthopedic surgery patients, anticoagulant prophylaxis was used much earlier than in trauma patients, because I believe of this concept of high bleeding risk. So over the years, there's been a significant decrease in clinically important VTE related not entirely to thromboprophylaxis, but to other dramatic improvements in trauma care. And many of you are involved in that concept change. And so the concept that at least I have now is very different than it was 25 years ago. And clearly trauma patients still come to the trauma room trying to bleed to death. And you guys fix this problem generally fairly quickly. And for most trauma patients, that bleeding risk goes down very promptly with interventions that are done to control bleeding. While thrombosis still sometimes occurs fairly early, most clinically important thrombi in these patients are delayed, and the there's a window of opportunity between high risk of bleeding and high risk of thrombosis that allows one to implement anticoagulant prophylaxis. And this concept of starting early anticoagulant prophylaxis has dominated the literature and clinical practice probably for the last 10 to 20 years. As far back as 1989, a study was done to show that 60% of trauma patients had evidence of deep vein thrombosis on a contrast venogram. We did a study looking at incidence of VTE in trauma as well, and we showed that more than half of those patients had asymptomatic DVT about 7 to 10 days after their injuries. And looking at a large volume of evidence from many investigators, these are some of the risk factors for VTE and trauma. Spinal cord injury patients have the highest risk of thrombosis, followed by pelvic and lower extremity fracture patients. Age is an independent predictor of thrombosis in trauma. We've and others have shown that if you're 30 and have a certain injury, your risk of getting a clot is bigger than if you were 20 with the same injury. There's good evidence that delaying prophylaxis is associated with development of VTE. And then a number of other issues a number of other factors have been shown to be predictive of thrombosis, major head injury, having a femoral venous line, the severity of the injury, surgery, reduced mobility. And we now know some other things that are relevant to the risk of VTE and trauma, some of which will be discussed subsequently. So patients who have a low anti-10A level when they're on low molecular weight heparin appear to have a higher risk of thrombosis. Low antithrombin levels, which we're going to hear much more about, also predictive. There are issues related to prophylaxis, waiting too long, using too low a dose, or missing doses that are associated with thromboembolic events. And most importantly, there are systems issues that dominate the prevention of VTE and that we need to address. Interventions that are essentially, I put in quotes, no longer used. Almost no low dose heparin is used in trauma anymore. The very prolonged delay of use of low molecular weight heparin in traumatic brain injury and other organ injuries doesn't occur anymore. Using a fixed dose of low molecular weight heparin in everyone doesn't make sense, given a lot of the evidence that's been accumulated. Routine screening for asymptomatic DVT, at least I personally think, is not an effective strategy to prevent clinically important outcomes. And now prophylactic IVC filters are not considered to be as useful as in the past. So I'm going to end with just two slides on what I think are the priorities in prevention of VTE and trauma. And there's three of these, the priorities that I think are the most important. So, yeah, we should probably try and develop better and simple predictors of risk of clinically significant VTE in trauma and in trauma subgroups. It would be nice to have better predictors of patients' risk of thrombosis. Is there a role for new modalities of prophylaxis? Maybe. There are around the corner drugs called factor 11A inhibitors, which are effective anticoagulants, but seem to be associated with a very low risk of bleeding. Maybe that will help us. But I think really better use of existing modalities of prophylaxis is what we know we need. I don't think we need new modalities. I think we need to use what we have better. We need randomized trials of various prophylaxis strategies. For example, using weight-based low molecular weight heparin versus some other adjustment strategy of low molecular weight heparin based on anti-10A level monitoring or antithrombin or some other factors. We need randomized trials with rigorous outcomes. I think there's a huge role for direct oral anticoagulants in trauma patients beyond the initial resuscitation phase. We use DOACs very commonly in trauma patients now after patients are stable and able to take oral medications. And certainly when patients go to rehab, they go from our place, they go on DOACs. We need really high quality studies to assess the implementation of thoughtful prophylaxis. And Elliott Haut is one of the international leaders in this area, but we need more studies to get all of us to do what we should be doing. I think it would be important to address VTE in the rehab phase and also in the phase after hospital discharge. So I'm going to stop there and turn this over to the real important and interesting part of the discussion today. Thank you.
Hey, Bill, that was great. And I put in the chat, we had a VTE and trauma conference last year. And if you're interested in seeing more of the talks, that was kind of part of that was an overlap of what Bill told us in person when we met. But there's a lot of more information that's in the chat. We're going to turn it over to Jessica to kind of talk us through the history, the ideas, et cetera, behind the paper, and then some of the methodology. And then we're going to open it up for questions. So just as a reminder, if you have questions, the way it's going to be done is you'll put your questions into the Q&A, and I'll be looking at those and asking those verbally to the panelists.
Awesome. Thank you so much. And thank you to Bill for that opening. I read all of your papers. You're such an icon, and we would not be at this phase where we're at today, where we're somewhat tweaking advances in thromboprophylaxis thanks to your pioneering work. So, okay, so I'm here to present the paper that We published last year related to antithrombin activity over time and how that relates to responsiveness to prophylactic enoxaparin and risk of VTE in trauma patients. Okay, I do have these disclosures. The project I'm going to describe today was funded by Grifols, and I am a consultant for Grifols. Okay, so just to kind of get to the why we started this project, I want to provide a little bit of background, a little bit of past work, and then get into the meat of the paper. And I promise to be quick because I know I have 20 minutes to discuss all of this, but really just to provide a little bit of background that there has been a lot of work on trauma-related VTE and just the big picture takeaway of a lot of basic science and a lot of translational work is that hypercoagulability, blood hypercoagulability is at the core of VTE in general, but certainly post-injury VTE. We see pronounced induction of procoagulant mechanisms in trauma patients that translates to an increase in VTE risk, including increase in coagulation factor activity, secondary to activation of the coagulation system during bleeding. We see increased production of liver-derived acute phase reactants that include coagulation proteins such as fibrinogen and plasmin Pi1, which is an antifibrinolytic protein. We see a substantial increase in the release of procoagulant extracellular vesicles from platelets and leukocytes, as well as ongoing increases in the production of circulating levels of thrombin, which also translates to an increase in metrics of blood viscoelastic tests. So it's really well known nowadays that your ability to produce thrombin, which is a procoagulant enzyme that cleaves fibrinogen to form fibrin, is a key determinant of the structure and overall stability of fibrin blood clots. And the amount of thrombin produced will directly dictate whether or not you are at increased propensity of developing a bleeding complication as well as a thrombotic complication. And really, chemoprophylaxis is designed to inhibit the overproduction of thrombin using some really standard of care chemoprophylactic agents that are in use today. Most commonly, the one used in the intensive care unit is low molecular weight heparins, particularly enoxaparin, which is also known as Lovenox. Clinically, it's administered somewhere between 30 to 40 milligrams twice daily, depending on your weight. Some institutions use anti-factor Xa guided chemoprophylaxis. We use it at Memorial Hermann, which is the institution that Bryan practices at and that I'm affiliated with. Which uses dose escalations of 10 milligram increments to achieve an anti-factor Xa level within what we call a subtherapeutic range, or I'm sorry, subprophylactic range of 0.2 to 0.4 units per mil. So interestingly enough, these days, it's still somewhat controversial. Should we be dose adjusting using anti-factor Xa? Should we not? Some people say, yes, it's necessary, it's helpful. Some say, no, it's not helpful, it's not necessary. But at the end of the day, this is a nice paper that came out of Ken Proctor's group. What we know is that when we have used anti-factor Xa guided dosing to adjust enoxaparin doses in trauma patients, we don't really see any changes in the overall incidence of VTE. So the question really becomes, why? Why is that the case? And we think the key to understanding or answering that question is understanding the mechanism of action of low molecular weight heparin and other heparinoids, which are really dependent on a protein called antithrombin. Antithrombin is produced by your liver. It circulates in your blood at a normal concentration of 120 micrograms per mil. It's measured clinically in percent activity with a normal range of 80 to 120%. It is the most important circulating endogenous anticoagulant in the body. It inhibits a number of different coagulation enzymes in the intrinsic as well as the common coagulation pathway. Most potently, it inhibits factor Xa as well as thrombin. And heparin-based anticoagulants work by binding to your endogenous antithrombin, and which causes a conformational change in the antithrombin molecule that increases its activity for inhibiting both factor Xa and thrombin by approximately 300-fold. So if you're treated with unfractionated heparin, you see both antithrombin as well as anti-factor Xa activity. When you give low molecular weight heparin such as enoxaparin, you have much less direct thrombin inhibitory activity and a more predominant anti-factor Xa inhibitory function. So we really got started on this project a number of years ago. It was a basic science project in a rat hemorrhagic shock model where we were looking at differences in the coagulation system after induction of hemorrhagic shock. And what we found is that this was sort of our first time where we really observed, in the lab at least, this acquired acute antithrombin deficiency secondary to major hemorrhage. And interestingly, what we found in this paper is that when we used fresh frozen plasma as opposed to a crystalloid-based resuscitation strategy for transfusion, we found that not only did this restore circulating levels of antithrombin, but that was also associated with a reduction in overall systemic plasma hypercoagulability, which led to the conclusion that plasma-based resuscitation is not just pro-hemostatic, as long thought. It's what we would consider pro-homeostatic, as it restores not just your circulating procoagulants, but also your necessary circulating anticoagulants as well. In the far right, we used a biorepository. Houston has a very large 10,000 patient sample biorepository of plasma samples of level 1 trauma patient activation samples collected on admission. We validated these findings in those samples as well, in which we spiked in fresh frozen plasma into those samples and saw a reduction in the overall procoagulant potential of the plasma, which did not occur if we spiked in plasma that was immunodepleted of antithrombin. So really, the question became something that was probably extended outside of my own personal expertise in the lab, and was really born from conversations that I had with Bryan Cotton related to, this is the phenomenon that we're seeing in the lab. What do you think is going on clinically concerning acute antithrombin deficiency in trauma patients? And what do you think it means? What do you think we can do about it? So this is a scenario in which I really think that the teaming of clinicians and scientists together kind of make this dream team. And from there, the project really, really accelerated and blew up from a lab-based project to a retrospective project to a prospective project to the steps that Bryan's going to tell you about today. But what we found when we looked at this clinically is that acquired antithrombin deficiency in a group of trauma patients that had really severe injuries, this is a secondary analysis of the proper database that enrolled patients that were predicted to receive a massive transfusion. Most of them, 75% of them, were in hemorrhagic shock. We found that the incidence of acquired antithrombin deficiency in those very, very, very sick patients was approximately 70% on admission. And that if you had an antithrombin activity level less than 80%, you were at over 3-fold increased risk of developing VTE during hospitalization. We sort of took the next step to say, okay, well, if we know the antithrombin deficiency is common, it's related with VTE, what does this have to do with how patients are responding to prophylactic anticoagulation with enoxaparin? So we yet again did another retrospective study. We used biorepository samples where we simply asked the question, how well compared to healthy individuals do trauma patients respond to enoxaparin that's spiked in ex vivo? And what we found is that compared to healthy donor, healthy plasma samples that were spiked with a set concentration of enoxaparin, in this case, it was 0.13 units per mil. What we found is that in the healthy donors, we saw 55% inhibition of thrombin generation in healthy samples, peak thrombin generation. We saw a 65% reduction in the rate of thrombin generation. Conversely, when we looked in the trauma patients, we saw only a 24% reduction in peak thrombin generation and a 39% reduction in the rate of thrombin generation, indicating that they were not responding nearly as well to enoxaparin as the healthy donor samples were. Interestingly, what we found is if we spiked in antithrombin ex vivo and remeasured both their anti-factor Xa levels as well as measured thrombin generation, we saw a significant increase in anti-factor Xa levels as well as significant reduction in thrombin generation. Some hospitals, it's kind of common practice if a patient is not responding to enoxaparin, they're given a unit of FFP with the underlying rationale of being that fresh frozen plasma contains normal circulating levels of antithrombin. We tried this ex vivo. We did not see the same robust effects that we did with using purified antithrombin concentrate. So that kind of brought us, that retrospective approach brought us to the research topic in the paper that we recently published here, where we wanted to validate some of these findings using a prospective study where we could sample patients longitudinally over time and look at time-dependent changes in not just antithrombin, but how patients were responding to enoxaparin, and use kind of a similar spiking study ex vivo. So we had three main objectives. One was to evaluate time-dependent changes in antithrombin activity between trauma patients that did and did not develop VTE. The second was to determine the link between these time-dependent changes in antithrombin activity and how patients were responding to enoxaparin as measured by their anti-factor Xa levels. And the third objective was to examine, using ex vivo approaches, whether supplementation of antithrombin would increase anti-factor Xa levels, specifically amongst patients who had subprophylactic anti-factor Xa levels. So this was a single-center prospective observational study conducted here at Memorial Hermann Hospital and the University of Texas Health Science Center at Houston between 2019 and 2020. We sought to enroll patients who were adult, level 1 or highest level activation trauma patients admitted to the trauma service. We capped the age at 70 to limit the number of patients that we would accidentally include in the study that were on pre-hospital anticoagulants. And we were specifically looking for patients similar to what Bill told us were some key risk factors for VTE, including those patients who had both either polytraumatic injuries or had a pelvic and or long bone fracture. We excluded patients who were prisoners, pregnant, big burns, had a non-survivable head trauma, who had a known hematologic or immunologic disorder, as well as those that we knew were on pre-hospital anticoagulants. So during the study period, the study period is about 14 months. We screened 2,150 patients. We excluded 1,019.30 for exclusion, meeting exclusion criteria. We further did not enroll another 87 patients who either declined consent or who were discharged prior to being able to get consent. That left 237 patients. We had 237 patients who were eligible, of which 87 declined or could not be consented, leaving 150 patients who were enrolled in the study. Of those, 28 patients, which is approximately 18% of patients, developed VTE. We had 12 DVTs, 14 PEs, and 2 patients who developed both a DVT and a PE. These are the patient demographics, their injury characteristics, and their outcomes. We didn't see any differences in admission demographics between groups. They had similar age, similar sex, similar race and ethnicity. We did observe that the patients who developed VTE were a little bit sicker than those who didn't develop VTE, as indicated by a notable trend and an increase in their, or a reduction in their base deficit. But there was no difference in overall injury severity scores. We did see that the VTE patients received more blood product transfusions over the first 24 hours. Patients who developed VTE also had fewer ICU and hospital-free days. There was no difference in overall mortality, and there was no deaths that were directly attributable to VTE in this population. So we collected blood samples prospectively for the first 8 days of the patient's hospital stay. We banked the plasma, and we used those plasma samples to measure antithrombin activity using an ACL top coagulation analyzer over time. And this is what we found when we compared patients who did and did not develop VTE over time. We found that upon admission, the AT activity was significantly lower in the patients who developed VTE. We also found some interesting trends in AT activity over time longitudinally, in which we found that generally for all of the patients, we saw this sort of acute reduction in AT activity over the first couple of days, followed by what we observed was a rebound in AT activity amongst patients who didn't develop VTE, which was not apparent in the patients who did develop VTE, with significant differences at these later time points between groups at days 5, 6, 7, and 8. We performed multivariable logistic regression modeling to determine what the independent association of AT activity was for predicting the development of VTE. We controlled for some known risk factors for VTE, including age, sex, obesity, and their injury severity scores. And what we found is that AT activity was a significant independent predictor of the development of VTE with an odds ratio of 1.52. That meant that for every 10% reduction in AT activity, the fold risk of developing VTE the patients had a 1.52 fold increased risk of developing VTE with a p-value of 0.007. We also did in multivariable modeling note 2 other significant risk factors for VTE that were identified, including the female sex as well as obesity. Even when controlling for these factors, though, we still saw a significant effect of AT in our modeling. So one of the questions that we had was, if AT deficiency is so common, what is the mechanism that's driving this AT deficiency? So in order to answer that question, we looked at 3 key underlying mechanisms that could be causing this. One is a reduction in the liver production of antithrombin due to altered liver function. Another one is consumption of antithrombin due to its binding by thrombin. And finally, it could be either inhibited or inactivated by circulating neutrophil elastases. So what we did is we took plasma samples, we measured thrombin antithrombin complex formation as well as neutrophil elastase levels by ELISA, and we collected liver enzymes, AST, ALT, and as well as albumin from the medical records. And we performed Pearson correlation analyses with the patient's AT activity to determine if there was any correlation between those factors and AT activity. We did not see any significant correlations between AT activity and liver function, indicating that there was no significant effect of altered production of antithrombin from the liver. We did, however, see a significant inverse relationship between antithrombin activity and thrombin-antithrombin complex formation, indicating that to some degree, yes, antithrombin is being consumed by antithrombin. Interestingly, though, we saw an even stronger significant inverse correlation between antithrombin activity and the circulating protease neutrophil elastase, which is known to bind to and degrade antithrombin, highlighting a potential interesting role for activation of innate immune mechanisms in driving antithrombin deficiency in this population. So next, we wanted to ask the question of how patients were responding to enoxaparin over time as measured by their anti-factor Xa levels. So to do this, we measured anti-factor Xa levels over time in the patient plasma samples. We specifically looked at patients who had received at least 3 or more doses of enoxaparin. We excluded anybody who had not received at least 3 doses of enoxaparin, and we excluded anybody who had been transitioned to unfractionated heparin. This left a total of 110 patients for analysis. And what we found is that compared to patients who did not develop VTE, we saw that anti-factor Xa levels over time were significantly lower in patients who did develop VTE, with significant differences that were notable on hospital days 4, 6, and 7. We also looked at the overall frequency of achieving an anti-factor Xa level of 0.2 or greater. I'm sorry, I guess I should say the reverse of that. This is plotted the incidence of not achieving an anti-factor Xa level of 2 or greater, which was significantly different between the groups, indicating that not only was the time to achieving an anti-factor Xa level of 0.2 or greater prolonged in patients that developed VTE, the overall incidence of achieving a subprophylactic anti-factor Xa level in that group was significantly lower. So we further categorized patients according to what we considered a responder status. We defined 3 subgroups within this population of 110 patients according to how well they responded to enoxaparin over time. We considered a patient an always responder if they achieved an anti-factor Xa level of 0.2 or greater for every dose or plasma sample collected after their 3rd dose of enoxaparin. We considered patients transient responders if they sometimes did and sometimes didn't achieve an anti-factor Xa level of 0.2 or greater, but they had to have at least 1 anti-factor Xa level of 0.2 or greater during the sampling period. And then lastly, we had patients who were never responders, which is individuals who never achieved an anti-factor Xa level of 0.2 or greater at any time during the study period. The overall incidence of those three groups was, we observed that 16.4% of individuals were always responders, 60% or the majority were transient responders. They sometimes did and sometimes didn't. And then nearly 24% of the population was what we considered to be a never responder and never achieved an anti-factor 10A level of 0.2 or greater during the study period. Interestingly, we found that the incidence of VTE between those populations was very different. We found that when we looked specifically at always responders and transient responders, the incidence of VTE was very, very similar, 5.6% and 6.1%, indicating that you really just had to respond to enoxaparin sometimes, but not all the time, to have some protection against VTE. Conversely, we saw in the never responders, the incidence of VTE was nearly 31% in that group, so very, very high. When we looked at antithrombin activity levels over time between those three responder groups, we found somewhat of a dose response here, with the highest antithrombin levels being achieved in the always responders and the lowest antithrombin levels occurring in the never responder group, with significant differences between the three groups identified at hospital days 4, 6, 7, and 8. So lastly, we conducted an ex vivo spiking study to see if we could improve anti-factor 10A levels in patients who were identified as never responders. We selected 14 patients for this spiking study, as we had 14 patients that were never responders and had sufficient longitudinal samples collected to allow us to do this level of a spiking study. We spiked, supplemented into the plasma antithrombin levels up to 120, 150, and 180% based on their own baseline AT value for that sample. And we measured anti-factor 10A, thrombin generation, and clot formation after supplementing antithrombin. And what we found is the top one is the anti-factor 10A levels with a dashed line at our subprophylactic goal of 0.2 or target of 0.2. And we found that when we spiked in antithrombin, we could see a significant increase in the anti-factor 10A levels. Particularly, this was true once we went up to, this is 120, 150, and 180. We saw pretty good responses with 120 that kind of waned over time. Most patients achieved an anti-factor 10A level of 0.2 when we went up to 150, and all of them achieved an anti-factor 10A level of 0.2 if we went up to 180%. The data were very similar. When we measured thrombin generation, we observed significant inhibition of thrombin generation at these 3 doses. And finally, we also measured clot formation using a fibrin polymerization assay and found that we were able to prolong the rate of clot formation in these samples by spiking in antithrombin, but we did not compromise the overall ability to form a clot under static conditions. So here's a summary of our study findings. We found that approximately 24% of patients never achieved an anti-factor 10A level of 0.2 or greater during the study period. We only found that 16% of patients were always responders in this group. So really, it was pretty uncommon for patients to always achieve an anti-factor 10A level of 0.2 or greater. The incidence of VTE is significantly higher, nearly 31% amongst patients who were never responders. But it was very similar between patients who were always and transient responders. Patients who were never responders had the lowest antithrombin activity levels over time. And we found that antithrombin activity during the initial hospitalization period over those first 3 days is independently associated with developing VTE. And finally, when assessed ex vivo in patient plasma samples, we found that supplementing antithrombin improved responsiveness to enoxaparin by increasing anti-factor 10A levels and reducing thrombin generation, as well as slowing overall clot formation. So there's a few notable limitations to this study. One is that this was a single center study. Another one is that our institution does not do routine DVT screening. So this is really, we only had symptomatic VTEs in this population. So the relevance of our findings to asymptomatic VTEs is not known. We also enrolled very high acuity patients in this population that were admitted to the ICU, so may or may not be relevant to what we would consider all comers to the hospital or to the IMU service. And finally, we need to note that our ex vivo approach for supplementing AT and measuring ex vivo analyses of how well patients are responding to enoxaparin was a limitation using these ex vivo approaches. So just to conclude the study, what we found is that time-dependent changes in antithrombin activity are associated with responsiveness to enoxaparin and are an independent predictor of VTE occurrence in trauma patients. And these findings could indicate that AT supplementation is a future therapeutic strategy for mitigating inadequate chemoprophylaxis as well as VTE risk in this population. So with that, I want to open up the paper for discussion, and after that, I will pass it to Bryan.
Hey, that was great. It was a great summary of, not just regurgitating what was in the paper, because I felt like there was a little more history that I thought was helpful for me, and probably a few more slides and a little more data than was included in the paper as well. So I thought that was great. Thank you so much for going over that. I'm opening this up for questions. Just as a reminder, we don't have a way to call on people in the audience. So if you have a question, your options are type it in the chat, and when we can see it there, or you can use the Q&A function and type it in there, and then I'm willing to go ahead and ask some of the questions that way. So with that, Bill, I'll let you go first. I'm sure you might have some questions for them, and then I have a couple questions also.
Thank you. I just want to congratulate you on doing an incredibly elegant series of studies. I wish I had thought of this a number of years ago. So I really like to commend you on opening people's minds to thinking about this in a different way. I just want everyone to realize, as you said, that your data comes from a highly select group of trauma patients. So 7% of the screened patients were enrolled in the study, and they are among the sicker trauma patients, which is fine. It doesn't detract from it. It's just this may not apply to everyone. I am curious, though, why an 80% antithrombin level was selected. I understand that you want to look at normal versus abnormal, but I would have been interested in a dose response effect of this if you had done a cutoff at 70%, less than 70%, or less than 60%. Which are more in line with what we consider generally to be antithrombin deficiency in an inherited group. I wonder what you would have found if you had reduced the threshold for labeling people as antithrombin deficient.
Thank you. That's a very good question. I can't say for sure what would have happened if we had done that. I think we would have seen, obviously, a much lower incidence of what we would call antithrombin deficiency in the population if we had done that. What I will say is that in our past analyses where we did retrospective studies looking at, specifically, this is looking at the proper database, we used a number of thresholds for identifying AT deficiency to perform predictive modeling to see what threshold is really the most optimal for identifying VTE risk in this population. I really thought it was going to be, like you said, 60, 70%, the lower, the higher the risk. But in fact, the sensitivity for predicting VTE in this population was highest at 90%, which is well within the normal range. Interestingly, most patients are indeed within the normal range, but I think that what that speaks to is that this is a population for which there is pronounced activation of the coagulation system, and they are at very high propensity for developing thrombotic complications. Maybe they're microvascular, we don't always pick them up as VTE or something else. But I actually think that redefining what we would consider to be a normal range of AT, specifically for this population, may be in order simply because of kind of our past findings that you kind of have to go at or above the physiologic or typical hematologic definition of 80 to 120 to see most optimal effects. So that was really the rationale for not doing it. And how the data would have differed if we had did that is a very good question.
And interestingly, I was going to ask a related question because, when I looked at the data that in the paper, that the VTE patients versus not VTE patients, their activity level, the VTE patients was 91%. And I fully expected it to be really, really low. And, you explained to me why, that 91% is clinically different than the other group, which was 100%. So you answered two questions even before I asked the second one.
Yeah, I'll just add that we've screened, I don't know, probably about 2,000 patients. Like, I have a specific interest in thrombin generation, but looking at thrombin generation profiles amongst patients who are really, really sick, even when we look at patients who are in profound hemorrhagic shock, they're still procoagulant compared to normal healthy controls. So I think just redefining how hypercoagulable these patients are may help to kind of understand why one may be expecting to need to go on the higher end of having a comparable anticoagulant response to outcompete this procoagulant response.
I just want to add also, if I can, just one second, to compliment you again. And although you've done this in trauma, this will apply to other patient groups, ICU patients, COVID patients. You would expect to find exactly the same. And so it calls into question how we think about those hypercoagulable states in those patients as well.
And interestingly, if I'm reading the questions in the Q&A, Samuel Berkman asked a related question just like that. And it says, is there a common denominator between post-trauma antithrombin deficiency and peripartum antithrombin deficiency? And we know those patients are at high risk for VT as well. Have you guys started thinking about that? Is that another population in addition to the ones that Bill just mentioned?
That is such a good question. That is not a patient population that I have personally explored. I'm not sure what our accessibility to that patient population is. If somebody wants to collaborate with me on that topic, I would be very, very interested and really open to that. We have looked in the COVID population. We published a paper, and I think it was in 2021. We saw the exact same thing, that within the normal range, AT activity levels was most predictive of VTE. And interestingly, we did try to do a similar approach in those patients, looking at, of course, their incidence of having thrombotic complications is so high, looking at how they responded to enoxaparin. And interestingly, what we found is that the target anti-factor 10A level, at least at Herman at that time, for treating COVID patients was 0.6 to 0.8 as opposed to 0.2 to 0.4. And so they were really giving patients a lot of enoxaparin at that time. We just had kind of a hard time defining a specific role in terms of enoxaparin resistance in that population. They were just really aggressive with anticoagulation. But if anybody out there wants to collaborate with me on peripartum hemorrhage, please reach out to me. I would be very open to that.
So yeah, maybe that will be Samuel Berkman. I don't know Samuel, but feel free to reach out to Jessica directly, or if you need help, contact Taryn through NBCA. Bill, did you have some more questions? Because if not, I got a couple I'm happy to ask too.
I don't have any more questions, but as I was reading your paper, I was grappling with the whole idea of outcome events, like how you define an outcome. And I must say, like, we see, my service sees every trauma admission to this place, and we follow them, some of them, until they're discharged. So like a third of the weeks of the year, I see all the trauma admissions. And I have a hard time deciding who would have a symptomatic DVT or PE. Because the orthopedic patients are all going to have either dressings or X-fixes or leg swelling. The chest injury or multi-system organ failure patients are on a ventilator. So I don't see myself a lot of symptomatic DVTs or PEs. Most of the events that we see are really asymptomatic. They're found because they have a CT, because they're looking for pneumonia or for a pelvic abscess or that sort of thing. And so I grapple with that, how you define symptomatic events in sick trauma population. You must be better clinicians at deciding this than I am.
I'm going to pass that one to Bryan.
Yeah, so this is a pretty sick population we're talking about. And when I first came to Houston in 2009, we had a moratorium, or at least an extreme view of prophylaxis and VTE in ortho patients, spine, head injury, especially the acetabulum, bad pelvis stuff. And we were seeing a lot of our young trauma patients literally drop dead from PEs and not rescue them. And that was one of the things we started tackling, was just getting more and more aggressive about the timing of it, which we are now pretty much on admission, with the exception of heads. Even that includes solid organ injury in everyone, no matter what your grade. Unless we're literally taking out your spleen, you're getting a dose of enoxaparin at the same time. And so I think we are more, I'm not going to say more, we are very primed and itchy to CT people that are tachypnic and tachycardic, that may just have a SIRS response, may be unrelated to a PE. And so we have a pretty high rate of PEs. I think it's part of that is reflected in our screening, or our likelihood to grab a CTA of the chest like that. And I don't mean just because they got a cough. I make a joke that if you cough, you get a CT of the chest here. But in reality, these are tachycardic, tachypnic, may or may not have a saturation episode, and then we scan them and they have a PE. Now, maybe that's the cause of it. Maybe it's also because they have pneumonia or acute lung injury or what have you. But I think it's just very much on our radar for these, versus DVTs, where we are not aggressive about seeking those out unless they are, like you said, symptomatic. So if you look actually at our TQIP numbers, our American College of Surgeons numbers, our PEs are much higher than most places, but our DVTs are almost unheard of because, again, we don't look aggressively for them, and at the same time have a pretty robust VTE prophylaxis strategy. So I think a lot of it has to do with that, to bring your question in, Dr. Geerts.
And I had kind of a similar question, Bryan, because your rate of 18% seemed overall a little bit high for me. And interestingly, on your regression model, injury severity score was not associated with VTE. And I was a little surprised by that. Usually we think of, the sicker patients are the ones at higher risk.
Yeah. So I think what is skewed and may not have come out in that paper and or in practice was that this population was almost exclusively ICU patients. And so their ISSs are going to be very similar. Their degree of shock is going to be very similar. So I think that's where a lot of the gross metrics of severity of illness were very similar in the study, because we focused on a place where we were already getting 10A levels. We were already being aggressive. So we kind of even though we're very aggressive about starting VTE prophylaxis at the door, when you're in the ICU, we've ramped it up a notch to the 10A levels, some of them in the IMU, but mostly it's ICU. So I think that's probably why a lot of your traditional variables were a wash, is because this is an incredibly sick population. Another thing to think about here is versus traditional numbers of VTEs and events, to put it back in perspective, a real quick history lesson. When you and I were fellows, the mortality for a massive transfusion patient was over 50%, almost 60%. When I did my first massive transfusion study at Vanderbilt and that 2004, 2009 range, the survival rate or mortality, for massive transfusion was 50%. It is now currently in most centers 18 to 20%. We are saving a lot sicker patient population that now has the sequelae of survival. And, that's a good thing, but now we're seeing more VTs. I will tell you, our VTE rates seem to, even with our increased aggressiveness, our less missed doses, our on top of everything, we've still seen in our sickest population a creeping up of our VTE rates overall. It has not dropped off the map like we thought it would. It's almost a never event on the floor. It's very uncommon in the IMU, but it still tortures us in the ICU. But I will tell you, our ICU ISS and severity of illness has just gone up and up and up. And again, it's a survivor curse at this point. Now we got to fix that, which is kind of how I stumbled into it. It was just like my patients I was high-fiving were now getting these massive PEs or this other stuff. And because they had survived, I'm like, I'm following them. And now we're again, with Jessica's help and others, starting to tackle this stuff.
Great. So I realize we're running short on time. I wanted to give Bryan a couple minutes to kind of talk about future directions. You know, every good paper is not the last paper you've written on the topic. Every good paper is going to be the what's the next step? What's the next project, paper, research, whatever that you're going to do. So Bryan, you're up. You're on mute. You're on mute.
Sorry, this is the next step in what Jessica's just talked about. It's our next, definitely not the pinnacle of it, and it's just the next tackling of this problem that is torturing us. We are both doing both PIs on this study looking at antithrombin added to prophylaxis to see if we can fix things. And just like Dr. Cardenas, myself, I receive research funds, and we both serve on the scientific advisory board for Grifols. I don't need to cover this. You guys know it. It's a big problem. And in our population, in the ICU, we haven't made that big dent like we have on the floor patients or in even the step down status patients. She's already covered a lot of this. This is a stepwise process. It's been beautifully done by her and others. Michelle Park, mine and Elliott's co-fellow from Penn, has done a lot of work in this arena as well. And it's just been a very stepwise, beautiful additions as we go up the chain. And one of the most surprising things is that a lot of what we thought was enough in antithrombin is not enough. And again, a lot of it has to do with just how severely injured these patients are. And in trying to answer all these different questions, it had led us to the more recent study that Jessica just presented very nicely in that summary of what our problems, what our challenges are. And as we've gone up and up and up, we've been finding this number of about 150 that seems to be where we're going to get, at least if we're using anti-10A levels, which we do at our center, and if our cutoff is 0.2, and if that's our trigger to start treating people, it looks like we need to be in that 150 range, which brings us again to Jessica's last study she talked about and some of the things. And the striking thing to take away, if you take away nothing else from this, if we could just get one anti-10A level of 0.2 or greater, in that first week, just one anti-10A level therapeutic, it was almost the exact same as if every anti-10A level that we had was therapeutic. But if we never got it in that first week, maybe they got it later on, but if they never got a 10A of 0.2 or greater that first week, they had a 30% risk of VTE. So a huge, huge increase if we can never get you there. So we have a study, three different centers, ourselves, Colorado with Michael Cripps, Vandy with Brad Dennis, and we're putting together, and these three centers were chosen carefully, not because we're all buddies, but more importantly, I sought out Elliott first, but we needed centers that used the exact same thing they did after the third, or right before the third dose, or right after the third dose, getting 10A levels and escalating doses from there. So all three of our centers practice very similar, so we wanted to see how it performed. It's powered for about 314 patients. We're going to be randomizing them to either placebo, or they're going to get a dose of antithrombin 3 to get their antithrombin levels up to about 150%. We're going to be looking at VTE as well as prophylactic 10A levels that are in that 0.2 to 0.4 range as our primary endpoints, with some other things that we're capturing obviously along the way, very dense basic science laboratory analysis as well. But our hypothesis is if we can randomize patients to AT3 infusion just one time even, we can get them over that hump of that thrombin generation and that antithrombin deficiency in that days 3 to 5, we can actually get them their 10A levels up quicker and get them to a lower risk of VTE with the hopes of no adverse bleeding outcomes at the same time. So that is pretty much the study in a nutshell. It's very similar. You just saw Jessica put this up in the other study. It's very similar. These are ICU patients, 18 and up, polytrauma, pelvic long bone. We exclude the 3 Ps, right? Pregnancy, prisoners, and peds. And then obviously other people that have anticoagulant prior to that, and or people we can't get enrolled in time, because we're getting consent with this study and we're getting them randomized before that 3rd dose of enoxaparin is administered. So these are our 2 arms, an antithrombin infusion prior to the 3rd dose to get them to 150%, or a normal saline infusion before that time frame. And back to you.
So with that, we are at time. I wanted to say thanks on behalf of the National Blood Clot Alliance for, the panelists, Bryan, for you and Jessica presenting this project, telling the history, talking about the paper, and telling us about the future directions. Bill, thanks so much for joining, NBCA on the Medical and Scientific Advisory Board. We on the board of directors really look to you and the other worldwide expert clinicians on that group to really guide the science of where NBCA should be going. So Taryn, I'm going to turn it back to you. Is there anything else you want to kind of close out with? You're muted.
Thanks, Elliott. And I just wanted to reiterate what you said and thank everyone, all the panelists for the presentation. It was terrific. Thank everyone for attending. We have a lot of information, both for clinicians, but also an incredible resource for patients on our website on stoptheclot.org. So I would definitely encourage everyone to take a look at that. We have a new patient guide, which takes patients through that first year after diagnosis. So I would certainly encourage everyone to look at that, and we'll be sending out a recording as well as some of these links to you all as well. Wonderful. Thank you so much. Have a wonderful day, everyone.
Thank you, guys.
Again.
Thank you.